Utilize neurologic protocols for patients with migraine and dysautonomia. Stay tuned because today you will discover low-tech assessment for respiratory patterns and balance and how to utilize oculomotor exercises to treat neurological dysfunction. Hi there, I'm Dr. Krista Burns, founder of the American Posture Institute and your host on the Virtual Neurology Summit. The purpose of the Virtual Neurology Summit is to provide healthcare professionals with brain-based solutions so you can get better neuroplastic results with your patients. I'm honored to welcome our next guest expert. Dr. Jason Smith is a chiropractic physician, a functional neuroscience practitioner, and a speaker on brain recovery. He believes that brain healing comes largely through simple daily habits. He leads by example and motivates others to take responsibility for their brain health. He loves to share techniques and strategies to accelerate brain healing so his patients can think, move, and feel well enough to live the life of their dreams. Today, he'll be sharing with us trusted neurologic protocols for migraine cases with dysautonomia. Dr. Smith, thank you so much for joining us as a speaker on the Virtual Neurology Summit. Please take it away.
Thank you so much for having me today, Krista. I have some exciting things to share with you. Basically, the outline of our presentation today will be briefly going over some definitions of what migraine and dysautonomia is, and then sharing not a thorough assessment for everyone, but some key things that I think should be included in the assessment. And then we'll talk about a successful case outcome we had at the end. So I'll just get right into it. So looking at the definitions of migraine, we all know migraine. Many of us have family members. Maybe we've even experienced them ourselves, but we know it's complex. And it's a neurological disorder that involves multiple brain areas, including autonomic areas, affective, cognitive, motor, and even sensory functions. Dysautonomia, on the other hand, when related to migraine, shows a pattern of elevated sympathetic activity and altered parasympathetic. Sometimes it's too much and sometimes it's too little. But that's the basics for definitions. In the International Classification for Headache Disorders, it talks about the complex criteria that we have for diagnosing migraine. There's, of course, the with aura and the without. In order to diagnose a migraine without aura, you have to have 5 attacks that fulfill B through D. The headaches have to last 4 to 72 hours, at least 2 of the following characteristics, and then they have to have nausea and or vomiting with photophobia and phonophobia, light and sound sensitivity. And it's complex. So what I've noticed is a lot of people who come in who've been thinking they've had migraine headaches for years or even decades actually don't have migraine. Some have post-traumatic headaches. Some have other types of episodic or cluster headaches. But to me, it's not really so important to say this is this label or not, other than it helps give us some guidance on treatment. But looking at some papers, I found numerous papers, dozens and dozens, that talk about migraine and dysautonomia. In this one paper by Gazzarani, he says, features of migraine attack that are indicative of altered autonomic function include nausea, vomiting, diarrhea, polyuria, eyelid edema, conjunctival injection, lacrimation, nasal congestion, and ptosis. So there's lots of different symptoms that seem to spread over lots of different body and brain areas. In this other paper in cephalalgia, it talks about the prevalence of headache with postural tachycardia. And I will share a little bit from one of my papers I wrote while I was working on my master's degree a couple of years ago. And we'll highlight the case study from that. There's another paper, episodic migraine in POTS. So I don't want to make it seem like it's only POTS, is that only dysautonomia that's relevant, but a lot of times there's hypothalamic pituitary adrenal axis dysfunctions. They're either too responsive or sometimes they're too little responsive, and it basically just exacerbates the symptoms of POTS. So let's talk briefly about the phases of migraine. And most of us know that there's a premonitory phase, an aura, a headache, and a post-trome. The premonitory can start anywhere from a few hours to sometimes even days before the the headache actually hits. And then once you get an aura, there's that common is that sparkly circular pattern that people have, but you can also have weakness, sensory sensations, tingling, numbness in the face, or even difficulty communicating that can last 60 minutes, but even in 25% of the cases, it's longer. One thing that we should note is that only about 30% of people with migraines really even have aura. So don't be distracted or thrown off with that if there's no phase 2. The headache is the most debilitating component. It's throbbing, pounding. Most of the time, early it's unilateral, but it can become bilateral. There's often nausea or vomiting, and then extreme sensitivity to light and sound and smell, and even hypersensitivities to touch. And then as I was learning into the post-drome stage 4, about 90% of people experience this, and it tends to dominate with being really tired. A lot of people call it a migraine hangover. And there's also some sluggishness cognitively, and then some neck stiffness. So I just wanted to review the symptom patterns of dysautonomia. And I have, in previous talks, I've talked about this cool paper I found on the dysfunctional patterns or the trajectories of mild traumatic brain injury, and it's called Coach CV. I don't have that paper in here, but you can find it. It's on open access for journals. But that's a great one to help keep you on track when you're looking at the different brain regions. I couldn't get a great acronym for you today, but I'll just go through these little 8 symptom patterns. And it starts with cardiovascular, which is anything related to hypotension, tachycardia, even bradycardia. And sometimes that palpitation will make people feel like they can't breathe very well. Then there's ocular abnormalities with the pupil, and the trigeminovascular system gets involved, and the face can have all sorts of interesting, painful symptoms, as well as even in the neck. Then on the digestive side, there's everything from nausea to diarrhea, from sleep apnea, fatigue, of course, when you don't sleep well because you've got a headache. And then there's all sorts of sleep-related periodic limb movement disorders and narcolepsy that sort of can fall into this dysautonomia pattern. And then the last 4 symptoms are respiratory, which it's not just you feel a panic or a tightness in your chest. A lot of people are having restrictions in their rib cage, and so they're overbreathing. And that needs to be addressed, I think, in order to resolve most of these migraine cases. I had one case that she literally had a migraine for over 500 days, every single day. She'd been to all the doctors around me in this clinic and in this town, and we were able to treat her. And her main dysfunction was this respiratory, and that really made a difference to get her rib cage moving so she could have normal respiration. On the cognitive side, you can have anything from brain fog, or as a patient told me today, just constant mental sludge. You just can't seem to think very clearly or quickly, and then you just forget things. So it does look a lot like a brain injury. And I think in most of these cases with migraines that are repetitive, they do have some overlap with the cortical spreading depression, and it's a similar pattern in seizure. And I think you affect all these memory centers as well. The last 2 are vestibular and bladder. I think that's pretty obvious. Vestibular affects our ability to maintain stability in the environment. And then the bladder can create a whole bunch of trouble with incontinence and urgency. And then I just put these other couple in here, altered sweating, which necessarily isn't bladder, but I didn't know where else to put it. So I put it in there. So there's lots of different triggers we need to be aware of, everything from diet to timing of our schedule and our sleep to hormonal changes in men and women, environmental factors like altitude, going in airplanes or different altitudes in the area where you live. When you travel, sometimes the altitude changes. A lot of brain injury people will tell me they go to sea level from, here around 4,300 feet in Utah, and they'll feel a lot better. But then they come back and they start having a lot of symptoms again. But it's not just from high to low, but I have people that go from low to high that also get triggers. So everything from head and neck pain, injuries, physical exertion, stress, anxiety, letdown, but also good stresses can trigger migraines as well. And then head trauma. So the most commonly known that I've learned back when I was in chiropractic school 28 years ago is things like menstruation, poor sleep, bright lights, cheese and wine. And I left chocolate off here because I didn't want anyone to be throwing tomatoes at me, and then low blood sugar. So those are the most commonly known triggers. And you see that stormy background. That's why I put it there, because it's like things are getting triggered. The less commonly known triggers, or the more overlooked triggers, are things like neurologic dysfunction. Could be anywhere from bulbar symptoms in the cranial nerve or the brainstem to cerebellum. Just other types of hormones besides just female hormones. There's progesterone and some of the other stress hormones as well. Insulin being elevated can actually increase it. Chronic inflammation, cervical spine injuries, and nutrition. I think we have to look a little broader beyond just wine and cheese and chocolate and alcohol for people who have triggers. I've seen lots of people triggered from wheat and dairy and soy and egg and yeast. So there's a lot of those. So when I evaluate a migraine case that seems to have dysautonomic patterns, I think every one of these cases deserves a full, thorough neurologic exam, but I'm just highlighting a few of the things that I do that are a little bit different to that have been sort of home runs in some cases. So the first thing I mentioned earlier is the rib expansion. And we just use a simple cloth measuring tape. We do it seated, and you'll look at different patterns of rib expansion where the younger you are, say in your teenage years versus, in your 80s, they say that every year, every 10 years, your rib expansion should go down an inch or two. And I don't really agree with that. I've had 80-year-olds that come in at 1 centimeters of rib expansion, and within a few weeks, they're breathing at 8 or 10. And things change. So that's the first one. Looking at the vestibular cardiac reflex in the tilt chair, we have a little zero gravity chair in my office, and I like to use the real-time pulse oximeter, and I'll explain how I do that in just a minute. We also like to never forget to look at the neurologic systems of the brainstem, the ocular motor, the vestibulo-ocular reflex, and vestibulospinal reflexes, and look at these. If you don't have a oculography system, then just do these tests bedside, and you'll get a lot of valuable information. And then the final thing is looking at how critical it is to evaluate the cervical spine properly. Do seated ranges of motion, and then do stress x-rays of the neck, which includes the lateral cervical and the AP open mouth and lateral bending open mouths. So those are pretty important. If you don't know how to do those, you should learn how to take those films and get it accurately so you can see those joints. So I found not a lot of papers on the lifting techniques that I've used. I have adapted some of it from Dr. Carrick, and I've done my own sort of style. But what I found is people who get rib expansion improvements also have symptom decrease. Their pain goes down, their circulation improves, and the thought in this paper was we're improving the diaphragm mobility, and that means your lungs ventilate better. Here's just an example from a paper in the JMPT that shows how you measure it. And I just sort of overlap those ends, and I have an alternating black and white area of the measuring tape, and it just helps me figure out where that transition is. I usually have them do 2 or 3 deep breaths, and I just measure the translation. I'm not measuring anyone's circumference per se to see how big that is. I'm just looking at for the translation from all the way maximum inhalation to maximum expiration. And then I just make a note. And I've been doing that in all my patients, literally every patient, probably all close to 10,000 patients now over the last 15 years. And so I've seen literally just a simple rib adjustment of that lifting from behind makes a huge difference if you do it properly. It's very safe to even do on the elderly, and I'm very gentle with them. So now let's talk a little bit about the vestibular cardiac reflex assessment. In this, it's a little complicated. I put the instructions here, but basically I like the pulse oximeters that have the real-time information where if you breathe fast or run around, it'll change it. not the one that just spits out a number and says this is what it was at that moment. So I tilt the patient all the way back and I find their baseline for a minute or so. And then we just tilt them up 20 degrees. And I just watch the heart rate change. And if the heart rate is doing what it's supposed to do, it should increase for about 5 or 10 points for within about 10 seconds. And then it just returns to baseline because the vascular system will tighten up a little and it'll keep that blood flow going to the brain. But if it doesn't, sometimes it goes down. If the heart rate goes down when you need a sympathetic stimulation to get it to beat when you're more upright, then that's not doing what it's supposed to. And if that happens, I'll just take them back down a couple degrees and I'll just have them do horizontal volitional saccades to these Brock beads that I'm holding in front of them about maybe 6 inches apart. I had put it to a metronome. Say they started at 90 and then their heart rate went down when it should have gone up, then I'll just have them do maybe eye movements for about 30 seconds and with the metronome beat at about 60 beats per minute. And you'll be so surprised. You can get those saccades to literally integrate somehow with the cardiovascular control centers to the heart rate, and it will literally change it. And it's a little tricky. You just keep working them up and it might take 5 or 10 minutes, but I usually just have to do that 1 or 2 times and people start to get more stable. That means people with POTS stand up and their heart rate doesn't jump from 80 to 150 and stay there. Their heart rate starts to be more regulated, and that means they can tolerate temperatures better. They can get up and down without feeling so dizzy. Their heart doesn't race so much, then their anxiety goes down. It's just really cool. So I like that. I think it's really important to do a VNG or some type of bedside ocular motor assessment. This is just a patient that I did recently who was in the dark and his eyes were just, I think he's around a 12-year-old kid, and his eyes were just moving all over the place. And his mom's wondering why he can't focus. Well, his eyes are moving even though his head's not. And so I'll talk to you about how maybe some exercises you can do for each of these dysfunctions in just a moment. But I think it's important to see these befores and afters in just a few treatments. And you see the patient start to feel like, wow, that test was a lot easier now. Sometimes it's really fatiguing for them to do these tests, even though they're not that challenging. So for gaze stabilization, I think most people who do any type of vestibular ocular work know that no-nos and yes-yeses are powerful. So I just have people look at a couple dots. It's either a diamond with one in the middle, and I just have them look at each of those at the 12 o'clock, at the 6, at the 3, and the 9, and just do 2 or 3 or 4 no-nos at each of those spots, and then 2 or 3 yes-yeses at each of those spots several times a day. So that's gaze stabilization. Pursuits, I got this from Dr. Rosenthal. He taught me the pot, the pedal, and the clock. So if you're holding a spoon and you're stirring something in a pot, it's going to be going in this plane. So you just put your arm in front and you do a tiny little, we're basically doing 5 snails, small getting bigger. You're looking at your thumbnail and you do it in that plane, and then you turn it this way and do it. And you look at 5 circles getting a little bit bigger, and then you do it in the clock pattern this way. So all 3 different planes. And if you work on those pursuits, just 5 in each direction a few times a day, you'll be surprised how much smoother your pursuits become in terms of the patient. Also, I really like to do saccades with the metronome, and usually we'll just have them look at a piece of folded paper with numbers and letters on the side and just go back and forth. And they'll go back down and up, and then that's one session, and they just do that a couple times a day. And then the last one, if the optokinetic system is not working right, that means when they move, their eyes are not fixating or refixating properly. I just like to have them lay on their back and do a 360-degree roll while they're slowly, maybe 30 seconds per 90 degrees going through. And it just retrains the system because we're getting gravity pushing onto the body at the same time you're getting that fixation. So I think these are very powerful, even though they're fairly simple. I literally haven't seen a chronic migraine patient yet who didn't have some ligament instability. So maybe I've only seen hundreds, but maybe I'll see some in the future. but it's really important to do stress x-rays on the spine to make sure that the feedback coming from the cervical ligaments is appropriate. And this is right down to C3 and 4 is where the trigeminal system loops down before it crosses over. And so these neck dysfunctions can affect the trigeminal system and create migraines as well. If you've ever had a time where you've looked up and then looked down and then got dizzy or fainted, you know that the position of your head and neck is really important. This is just a picture of someone that I had recently that had some pretty significant retrolisthesis at C3 and some degeneration. This person got bumped in the head, on the back of the head, by a 2,000-pound bull. Maybe it was 1,000 pounds. It was just big. Shattered his skull, knocked him out for about 4 hours, and lost his hearing in one ear, lost the ability to blink on the other eye. It was just a lot of neurologic symptoms, but we've got almost everything back. And, you know, he still has this instability in his neck, but everything's feeling amazing. So have to be aware of it. Here's another view. This is a teenager, a 16-year-old girl who's a wrestler who had 2 different concussions on the mat. And she had been treated by lots of different practitioners who hadn't looked at her neck. And they'd done a lot of great work. She actually ended up with a couple of seizures doing too much therapy, but that overhang is indicating that she needs to be careful in her neck and not have a lot of torquing and twisting. I think she ended up going back to wrestling, but she's been doing really well. So to summarize my case study, I presented this in my master's capstone project at Parker on my clinical neuroscience degree, titled Treatment of Postural Orthostatic Tachycardia Syndrome Using an Applied Functional Neuroscience Approach, a case report. Now, I haven't published this yet, but I hope to be able to publish it to get it good enough so it could be published. But this is a married man who came in. He was working at the Air Force Base, and he found me on a POTS Facebook group somehow. And he basically was almost disabled because of his severity of his POTS and his headaches. He was having fainting numerous times. He'd fainted over 70 times the previous year. And that was just like standing up at work to go to the bathroom or something. And there was concrete. And so he may have had dozens of times where he hit his head just from fainting. So he also had insomnia, trouble sleeping, gastrointestinal complaints, and cloudy weather really affected his ability to function. So we treated him using everything I just talked about. We treated him using the tilt table oculomotor rehab. We did transcutaneous vagal nerve and tongue stimulations. We did graded physical exercise, supported him with magnesium, and did rib expansion manipulation. Just that seated lifting adjustment. And he had such significant relief. 12 visits over an 8-week period with a follow-up at 6 months. His result, complete resolution of all symptoms, and he was able to return to full daily activities. He's a golf instructor, able to work. I've seen him, not in the clinic, but on occasion, I'll see him in town here, and he has a couple extra children now, beautiful daughters that he had that we got to get to know, and he's able to get his life back. So I'm pretty excited about, even though I feel like I don't know everything, I'm still able to do some things that can make a difference in the lives of these families, get their lives back. So in summary, I am so grateful to be able to have a chance to help people with all sorts of dysfunction. And I like to remind them that what lies behind us and what lies before us are tiny matters compared to what lies within us. And as practitioners, when we bring what lies within us out into the world, miracles can happen. And that's attributed to various people, but one of the research sources I found was Henry Stanskins. So that is my presentation for today.
Thank you so much for that excellent presentation. Thanks for making it so practical for us. I'm going to go through a summary and then a couple of questions. So, you talked about migraine, which is a complex neurological disorder involving multiple brain areas, dysautonomia being associated with elevated sympathetic nervous system output and altered parasympathetic nervous system activity. With headache, so in terms of diagnosis for migraine, it is quite complex. Headache disorders with and without aura, 4 to 72 hours, nausea, photophobia, sound sensitivity, and then among other symptoms, and they need to experience about 5 attacks. So features of migraine with altered autonomic nervous system function can result in body and brain symptoms. You share with us a couple of great research papers regarding postural tachycardia and headaches, episodic migraines and POTS, and how this exacerbates POTS symptoms. Migraine phases include premonitory, aura, headache, and then postdrome. Only about 30% of migraine patients have aura. Headache is the most debilitating component. Usually patients will say that they feel it coming on, and then the headache is going to be the most debilitating aspect. They also experience hypersensitivity of light, sound, touch, and smell. And then the postdrome is going to be like that migraine hangover, where they're still feeling the effects even though the headache has passed. With dysautonomia, it's associated with cardiovascular, so hypotension and or tachycardia. Ocular could be associated with pupillomotor dysfunction, trigeminal nerve irritation, digestive, nausea, constipation, sleep apnea, fatigue, respiratory associated with shortness and difficulty breathing, also restrictions of the rib cage, cognitive associated with brain fog, confusion, memory loss, vestibular, dizziness, motion sickness, and then bladder, urgency, incontinence, altered sweating, and sexual dysfunction. So with migraine triggers, things like diet, sleep, hormonal changes, environmental factors, head and neck, physical exertion, stress and anxiety, and head trauma can all be migraine triggers. The ones that your patients tend to have heard of previously include things like low blood sugar, poor sleep, menses, cheese and wine, and bright lights. Commonly overlooked include inflammation, cervical spine, nutrition, and neurologic, as well as hormones. And then clinical evaluation. So you shared with us some great assessments to perform, looking at rib expansion with the measuring tape, the vestibulocardiac reflex, zero gravity tilt chair, real-time pulse ox, and then oculomotor, looking at gaze stabilization, pursuit, saccades, and optokinetics. And with cervical spine, looking at range of motion, seated, also with stress x-rays. With the rib lifting techniques, so pain relief, local circulation, reduced inflammation, and improved diaphragm mobility, maximum inhalation and exhalation translation, looking for the measurement. And with strategies, multi-angle saccade stimulation with metronome, horizontal and volitional saccades to metronome for about 20 seconds. And then POTS patients will have a more regulated heart rate, really phenomenal. With the VNG oculomotor assessment, so eyes moving when head isn't, it's going to be hard to focus. You gave an example of turning out the lights and watching a child's, eyes just moving in space. And when their head isn't moving, this is going to demonstrate that it's very hard for them to focus. Gaze stabilization seated, looking at pursuits in all 3 planes, saccades with metronome, optokinetic slow 360 barbecue roll to the weaker side. And then looking at cervical ligamentous instability with stress x-rays and how that's impacting trigeminal. And you gave us a great case study, 28-year-old golfer with POTS, fainting and headaches, and just imagining how just brutal that would be for your quality of life, nearly completely debilitating. And, through these techniques, you were able to help really restore his life and function. And that is absolutely phenomenal. That's what it's about at the end of the day, restoring quality and quantity of life for our patients. Couple of questions for you. You talked to us about the rib maneuver, which is phenomenal. One of the things that we like to do at the American Posture Institute, we do a lot of anterior rib adjustments in addition to clavicle adjustments to really open up the rib cage. Is that something you would recommend as well? We do it more from a postural perspective, and then also it helps with breathing. Any other thoughts regarding opening up the rib cage and then continually helping the patient maintain that upright rib cage instead of them going back into this position in many
Yes.
cases?
You said it exactly. Like when I do it, I adjust the rib, I contact the front as I elevate the side as I do it from the back. So I'm really doing the front, the side, and the back quick stretch all at once. Some people can't tolerate it, so I just stretch it slowly. And in a lot of cases, I'll use instruments just to adjust each of those segments that are tender. And then, of course, the sternoclavicular area, I'll even do right where the scalenes attach behind the clavicle, and that sometimes can free up and do amazing things for breathing.
Oh, yeah, I can imagine that. That sounds really good. And then when you were talking about the barbecue roll move, can you talk to us about gaze stabilization during that? Do you move the head and then the body or the head and body simultaneously?
Well, I've learned several different varieties of this, and it depends on what they can tolerate. I had a seizure case who actually she's in this afternoon, but she can't tolerate looking like I like to put the glasses on. I learned from gravity reset method, Noel Cedric and his group, but some people can't tolerate it. So if they can tolerate it, I like to have them use the fixation on a target wearing a laser hat thing or laser glasses where it's projecting a dot. But a lot of people just at the beginning, I just have them slowly move.
Uh-huh.
Doesn't matter how they're doing it. Their head is usually on a pillow. So we're just moving everything together. Just
And you're
so
moving to the
they get
weaker
that
side?
angular gravitational pull on each of their spinal ligaments and all the pressure receptors on their skin. And
Mhm.
then they can use that as one of the ways that they can retrain their brain.
Nice. Excellent. Thank you. And as we wrap up another great session today on the Virtual Neurology Summit, I'd like to acknowledge Dr. Smith for his excellent work in functional neurology. And to all of our viewers, I'd like to acknowledge you. Thank you for your commitment to brain based correction and objective clinical results. I'm Dr. Krista, your host on the Virtual Neurology Summit. Be sure to check out the Postural Neurology program to get certified in brain based postural correction. Stay tuned, and we'll see you on the next Neuro Masterclass of the Virtual Neurology Summit.